On the occasion of ASPEN's 2021 Malnutrition Awareness Week, I would like to provide this short presentation on performing nutrition assessment remotely using telehealth. Hello, and thank you for having me today. My name is Nicole Hopsecker, and I am an outpatient dietitian for the Center of Human Nutrition within the Digestive Disease and Surgery Institute at the Cleveland Clinic. There are three objectives in this presentation. First, to explain telehealth and how it is used for nutrition assessment since the COVID-19 pandemic. Also, to describe how a telehealth nutrition assessment in the outpatient setting is conducted. And third, to recognize the barriers to conducting a nutrition assessment in the outpatient setting during a telehealth visit. Telenutrition is the use of telecommunications technologies by a registered dietitian to implement the nutrition care process with patients at a remote location within the provisions of state licensure. There are a variety of telehealth communication tools, but when telehealth is mentioned in this particular presentation, I am referring to the use of video conferencing in which both provider and patient can see one another with video cameras and hear one another through microphones. Telehealth is regarded as an emerging area of practice for many healthcare professionals, including registered dietitians, and guidelines for practicing with telehealth are in flux until a gold standard becomes consensus. Therefore, work to establish standardized practice is essential. Clinical judgment and staying up to date with changes in guidelines for practicing telehealth is crucial at this time in order to optimize patient care. In the presence of the COVID-19 pandemic, telehealth increased from 37% to 78% in the spring of 2020 in an attempt to abide by social distancing guidelines. Video conferencing allows for increased development of patient-provider rapport, as well as provider ability to share education material or other material to enhance the appointment via the video conferencing screen share tool. The use of video conferencing may be more beneficial in those particular populations that may be unable to leave the house frequently, for example, in those patients that are disabled or are immunocompromised. With the increase in the use of telehealth over the last year, it's no surprise that there was an increase in telenutrition. With increased use of a new modality in which to implement the nutrition care process, there are bound to be barriers and challenges to overcome. One challenge of telenutrition in the outpatient world is the ability to carry out a malnutrition assessment, and specifically the nutrition-focused physical exam. Most data collected during an in-person nutrition assessment is done via patient interview or medical record review, and these two methods of data collection remain available when telenutrition is being utilized. However, conducting a nutrition-focused physical exam virtually may need to be adjusted due to the inability for an in-person inspection or palpation. Energy intake and interpretation of weight loss can be obtained via the medical record review or patient interview, but the other four characteristics used to diagnose or support the diagnosis of malnutrition, which are highlighted in orange, are not traditionally obtained by patient interview. It is recommended that energy intake and weight loss be evaluated in all scenarios, and that clinicians should document physical findings as able and use clinical judgment in assessing and documenting risk for malnutrition. A virtually conducted nutrition-focused physical exam does require more patient involvement, and increased reliance on subjective data provided by a patient may result in inaccuracies. Tracking weight trends between scales may be difficult due to different calibrations among scales, not to mention the possibility of a patient to weigh himself at the virtual assessment and provide a false number. The lack of the ability to palpate may create difficulties in determining the severity of malnutrition due to inability to assess amount of fat or muscle lost. For example, a patient may exaggerate or underreport fat or muscle loss in certain areas, or they may fail to report the presence of edema or its severity. A barrier that is not necessarily new to the outpatient clinics is the ability to follow labs closely, as we do not take labs as frequently as providers on the inpatient side. In addition to these clinical barriers, other challenges present themselves. Challenges with technology, such as poor video clarity or connection issues, can affect the assessment. Insurance coverage for patients and licensure laws across the state lines can affect virtual health care as well. As previously mentioned, the nutrition-focused physical exam is conducted using palpation and inspection, which are viable tools during an office visit. However, when the assessment is done via virtual conferencing, both inspection and palpation are limited methods to obtain information. During a telehealth visit, inspection may be utilized to assess overall patient demeanor, if the patient is lying down during the appointment, or to note fat and muscle wasting of the upper body, such as the temporal muscles, orbital fat pads, and the pectoral muscles. Inspection may be used to assess dentition, changes in the mouth from micronutrient deficiency, or changes in hair if video quality is good. Apart from inspection, probing questions are essential to assess for changes in body composition, functional status, or changes in the skin, nails, hair, or the mouth. Asking questions such as, "Has your activity level changed?" may guide a clinician to note a decline in functional status. If a patient notes that their pants are fitting looser, this may signify fat loss, particularly of the mid-axillary line at the iliac crest. A change in the way a patient's glasses fit may suggest temporal muscle wasting, and difficulty opening jars or packages may signify muscle loss in the upper body region. Probing questions such as, "Have you noticed any differences in your hair or nails?" or "Do you have any trouble seeing at night?" may reveal micronutrient deficiencies associated with the hair, skin, or eyes. If video quality is good, the provider may ask his or her patient to hold their nails or skin in front of the camera to inspect any changes. Probing questions such as, "Are you having any trouble with bleeding gums?" may help the clinician to diagnose micronutrient deficiencies that affect the mouth. These questions are similar to questions you may have already been asking your patients in your outpatient practice, asking the patient if their ankles are swollen and encouraging them to press on swollen spots and measure the length of time any indentation stays visible may help a clinician assess edema. The clinician may also use inspection to assess edema if the patient is able to angle the camera towards their feet while pushing on their ankles. If family members are present, you, as the clinician, may ask the family members to help the patient hold and angle the video camera towards places that otherwise may be difficult for them to do on their own. Please return to these slides and read through this table for viable questions to ask your patients while you're performing a virtual nutrition-focused physical exam. We can now transition to putting the information we have reviewed into practice. To provide an example of a virtual nutrition assessment, I have a case study detailing information from a previous patient of mine that I saw in an outpatient clinic. This is a 73-year-old female, first seen virtually by nutrition therapy in June of 2021 via video conferencing using Zoom as a secure platform. Her consult for nutrition therapy was due to her unintentional weight loss and her diagnosis of amyotrophic lateral sclerosis, or ALS. Other medical problems, such as high blood pressure, prediabetes, high cholesterol, obesity, and anxiety, were noted in her medical record as well. She takes a variety of medications and at this time was awaiting a script for Cymbalta. To review, ALS, or amyotrophic lateral sclerosis, is a neurodegenerative disorder characterized by the atrophy of skeletal muscle. Prognosis for ALS is poor, and the prevalence of malnutrition in this population is high. ALS Clinic is an outpatient multidisciplinary clinic with a neurologist, a nurse, a registered dietitian, speech therapist, occupational therapist, and physical therapist. Nutrition impact symptoms vary patient to patient, but contribute to malnutrition and may include hypermetabolism, dysphagia, fatigue with breathing or chewing, or an overall decline in energy, constipation, self-feeding difficulties, increase in meal duration, sialorrhea, frontotemporal dementia, decline in respiratory function preventing peg placement, early satiety, and decline in appetite. The patient that I met with via video conference did endorse some nutrition impact symptoms. She reported mild swallowing difficulty. Patient had a modified barium swallow completed in June of 2021, which diagnosed her with mild oropharyngeal dysphagia, without aspiration observed in the study. The speech therapist did recommend to continue moist, regular diet and thin liquids, softening and moistening foods as needed for patient comfort and ease of intake. Compensatory swallowing strategies were discussed as well. Patient notes a decline in appetite attributed to psychological stress and depression after her diagnosis. She notes an increase in meal duration due to decline in hand function and dyspnea present, which may affect PEG decisions in the future. Patient endorses a usual body weight of 190 pounds, followed by a 32.6% weight loss over a 13-month time frame. Labs are not recent, but were within normal limits at the time they were taken. Note that blood glucose is slightly elevated, which is likely not an inflammatory marker, but a result of prediabetes. The patient was diagnosed with severe protein-calorie malnutrition due to weight loss greater than 20% in 1 year and energy intake less than 50% over 1 month. The etiology of this malnutrition diagnosis is of social and environmental circumstance, as her weight loss is attributed to decline in appetite due to psychological stress, and there is a lack of labs to support underlying inflammation. This slide demonstrates how the portion of the nutrition-focused physical exam that classically requires palpation was carried out, using questions from the aforementioned table. Inspection from video conferencing with the patient reveals wasting of temporal and clavicle regions. The patient was asked to angle her camera to show her face straight on, to where dips in the temporal muscles were visible. The patient was also asked to angle the camera towards her shoulders and move her shirt over slightly to where her clavicle was visible. Protrusion of the clavicle indicated wasting of the pectoral muscle. Patient endorses that her clothes and pants are falling off of her, signifying fat loss, particularly in the region of the mid-axillary at the iliac crest. The patient was asked if her daily activity has changed to assess functional status, to which she replied that she has been feeling weaker recently and feeling that she struggles to make her way up the stairs. During the video call, the patient was lying down rather than sitting up, suggesting decline in functional status. This observation was made without a probing question, as pillows were seen behind the patient's head. Note that this may have interfered with the perceived severity of pectoral wasting, as this exam is meant to be performed with the patient sitting up. The patient also reports increased time spent napping during the day, suggesting that functional status has declined. Note functional status may be impacted by ALS and depression in this case, in addition to malnutrition. I asked the patient if she had noticed any changes in the color of her mouth, eyes, or nails. The patient denied any changes at that time. She did endorse that her skin and mouth were both dry, which would support a decline in hydration status. Patient denied any swelling in her legs, stating that they were not puffy or swollen, and the patient was able to angle the camera towards her feet, so I was able to observe her fluid retention and confirm her statement was correct. This slide summarizes information discussed in the previous 2 slides. It's likely the patient suffered from muscle loss at the temporal and pectoral region. It's also likely she suffered from fat loss at the iliac crest. Support for this malnutrition diagnosis includes decline in functional status, as evidenced by fatigue, along with poor hydration status reflected in the patient's dry skin and dry mouth. I had the opportunity to follow up with this patient in person at ALS Clinic about 3 weeks after our initial telehealth meeting. Her malnutrition diagnosis remained the same despite the opportunity to include a palpable nutrition-focused physical exam. At this in-person visit, the nutrition-focused physical exam revealed moderate loss in fat pads and moderate to severe muscle loss. Further observation of the patient's mouth, eyes, hair, and skin were in line with the answers provided at the virtual assessment. A diagnosis of ALS can make a nutrition-focused physical exam difficult due to ALS-related muscle loss acting as a confounding variable. However, it's clear that at this time, the patient's nutrition status is poor and it is exacerbating fat and muscle loss. Inadequate intakes and weight loss continued to indicate a diagnosis of severe malnutrition, and physical observations of potential micronutrient deficiency remained the same. The patient was not up to her therapeutic dose of Cymbalta and continued to endorse a decreased appetite. She declined use of mirtazapine for improvement in mood and appetite due to Cymbalta's dual mechanism to reduce nerve pain. She did decline use of nutrition support as well. In conclusion of this presentation, telehealth and telenutrition strategy is an emerging area of practice. There are several barriers in obtaining the needed information to complete a nutrition assessment when using telehealth. The gold standard for nutrition assessment via telehealth is lacking, and there is a need for standardization and improvement in technology. Patient participation with technology during a telehealth nutrition assessment is essential. Probing questions are necessary to include during a telehealth appointment to assess factors that the provider may not be able to observe through technology. Confirmation of telehealth findings can be validated once the patient returns to the outpatient facility for a face-to-face clinic visit. The remaining slides provide a list of references used during this presentation, an important acknowledgement, and key details about ASPEN. I thank you very much for your attention and hope you found this presentation insightful.